Hey everybody, welcome back to the ECG channel. My name is Reed. Before we get going, go ahead and head to the description of this video and download the PDF, which is this document, so you can follow along and make notes. And while you're there, if you would like to subscribe to the channel, like the video, make some comments, would love to hear your thoughts. So thanks for watching. Let's get going. So first thing we're going to do with this strip is look at the forest and the trees of the forest from our QRSs. As you can probably already tell, V1 here seems to be a little bit of a wash, right? That for whatever reason the V1 electrode wasn't on right. That's okay. We can work through it. But what we'll do is we'll look maybe at this lead 2 rhythm strip. We see we've got what appears to be a wide complex QRS. If I zoom in, you can see it even better here. It's a pretty wide QRS. So we got a wide complex QRS. Seems to be regular, right? We're just kind of ticking away, and that seems to be the case all through. So we've got a regular wide complex rhythm. Let's look at the rate on this. So we'll find a QRS that lands right on this solid line, maybe this one right here. And we'll see we've got 300, 150, 100, and it's just a hair slower than 100. So we'll call this one maybe 99 beats per minute. This person is not tachycardic, just by a hair. So we've got a 99 beat per minute wide QRS. And I like to just take a glance and see, well, is this a sinus rhythm? What's going on? And yeah, I don't see P waves. So if you haven't watched yesterday's video, this will be fun, right? To contrast, a rhythm that's regular, but doesn't have P waves. What's going on? So let's look a little deeper, evaluate for our atrial activity. Let's just look for P waves before our QRS. We'll scan through a little bit more. We'll maybe look up here in lead 1. If I zoom in front of my QRS complexes, I don't see any P's that are driving my QRSs. I can do that throughout the ECG. Really not seeing convincing atrial activity. In fact, it's quite flat. Really doesn't make me think of, like, AFib doesn't come to mind. Nothing comes to mind. I look through the precordium. So I see no P waves. So no P waves. Okay, we've got no P waves. We've got a wide complex rhythm. What's going on? Well, we know that wide complex makes me think that this rhythm is not going through the normal His-Purkinje system, right? Because if it was, that highway system from the AV node down is what allows for my QRS to be fast and rapid and narrow. But in this case, you can see that our QRS here is maybe the width is probably 3 to 4 small boxes, so 160 or so milliseconds. And so that is, as we said, that's wide. So that makes me think that some type of conduction disturbance is occurring. And so let's just evaluate the QRS and work through what are the characteristics of this QRS complex. So the axis of my QRS, if you notice, is negative in all of my inferior leads. My inferior leads are leads 2, 3, and AVF. So my QRS, my wide complex QRS, is negative in the inferior leads. You see here, leads 2, leads 3, leads AVF. So if it's a negative complex rhythm from an inferior lead perspective, that tells me that the axis of depolarization is going up. It's going from down to up. And that is really not characteristic of AV node passing the signal down. And so what I'm kind of getting at, which a lot of y'all probably are kind of understanding at this point, is that this is a ventricular rhythm. Ventricular rhythm. It's coming from some ectopic focus. So there's some ventricular ectopy. Right, there is some focus. There is some focus somewhere inferiorly within the ventricles that is firing off, causing slow depolarization, not through the His-Purkinje system, through the ventricles, that is creating signals that are going away from the inferior leads. And it's going towards some of my superior leads, right? AVR and AVL. And so, well, we've pretty much said that this wide complex rhythm is likely a ventricular ectopic rhythm. What is some more data that could help us say that with more confidence? Well, we know that some people, their AV node here is actually capable of retrograde conduction of a ventricular ectopy. So this signal that is spreading through the ventricular myocardium is going to reach the AV node, and some people's AV node has the ability to conduct that and depolarize the atria in a retrograde fashion and create retrograde P waves. Some people do. Let's see if this person does. And so I like to look at leads like AVR for these. You can look in lead 1 for these. And we know that retrograde P wave is going to occur after the QRS. Should maybe occur within maybe 80 or so milliseconds, right? 80 to 120 milliseconds as, that AV node is conducting retrograde. So somewhere on the ST or T waves. We need to look on the ST segments or the T waves. And so we know that atrial activity is also sharp, little sharp conduction waves. And so I look in maybe AVR, and maybe I can see a hint of it right there, that little bump. Maybe that's some retrograde P wave. Well, we don't need to look at AVR in isolation. We can look at other leads. If we know that we've got retrograde conduction from the AV node into the atria, we know that the atria are going to depolarize from inferior to superior. That should create a retrograde P wave that is also pretty prominent in the leads that are in that orientation. So I look at my inferior leads, and what do I see? Instead of seeing this nice smooth, so here's my QRS, and then instead of seeing this nice smooth T wave, what do we see? We see this little notch. And that notch right there is kind of right on the ST segment, and I would say that is pretty solid evidence for retrograde atrial activity. You can look up here in lead 1 as well and also see we've got our QRS, and then on our ST and T wave, instead of it being a nice broad flat T wave, we've kind of got these little chunks, those little bites that are coming out of our ST and T waves, and we know that ST and T waves are flat. So I would say yes to our retrograde P waves, right? Because our retrograde atrial activation is going to create these little P waves. And so that gives us a lot more data and evidence that this is a ventricular ectopic rhythm. And so, because it's a ventricular ectopic rhythm, it's not tachycardic, we would call this an accelerated idioventricular rhythm, or AIVR. It's accelerated because we know ventricular ectopic focuses, usually these focuses beat at 20 to 40 beats per minute. They're pretty slow when it comes to their ability to fire off. When ventricular ectopic focuses fire off, it's usually slow, and we usually don't notice it because we've got sinus rhythms going on. But in this case, it's accelerated, but it's not tachycardia. So this isn't ventricular tachycardia. This is an accelerated idioventricular rhythm. And so, it's hard to look for pathological Q waves because we're not getting good normal conduction. It's hard to look at ST changes as well. This rhythm actually, in fact, was a rhythm that occurred after somebody had a percutaneous intervention on a STEMI. And so something that's interesting is that AIVR can be a very benign rhythm in the setting of reperfusion therapy for somebody that has had a myocardial infarction. So let's do what we always do. Let's put this all together. We've got an accelerated idioventricular rhythm with retrograde atrial activation. And someone goes, hey, where do you think this AIVR is coming from? Well, I would say it's coming from somewhere within the inferior portion of the ventricular myocardium. Why would you say that? Because we've got all these negative forces in the inferior leads telling me we've got signal going away from the inferior, which is going up towards the superior aspect of the heart. So I hope this helps, guys. If you have any questions, throw it in the comments, and subscribe to the page for more. We'll see you tomorrow. Take care.